Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 481 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. The next case reads: TSD is a 26-year-old woman with Philadelphia chromosome-positive acute lymphocytic leukemia in first complete remission, who is admitted for allogeneic myeloablative hematopoietic cell transplantation. The following orders are written. Admit to a room with a positive pressure HEPA filter. Flush double-lumen Hickman catheter per protocol. Immunosuppressed patient diet as tolerated. Begin fluconazole 400 mg orally every 24 hours and levofloxacin 500 mg orally every 24 hours on admission. Begin ceftazidime 2 grams IV every 8 hours with first fever when absolute neutrophil count is less than 500 cells per microliter. Transfuse 2 units of packed RBCs for hematocrit less than 25% and 1 unit of single donor platelets for platelet count less than 20,000 per microliter. So my question to you reads: what is the rationale for these supportive measures? As a result of disease-related immunosuppression, intensive preparative regimens, and post-transplant immunosuppressive therapy, patients undergoing allogeneic hematopoietic cell transplantation require careful monitoring for regimen-related toxicities and intensive supportive care directed at maintaining adequate blood counts, preventing or treating infection, and providing optimum nutrition. Placement of a double-lumen or triple-lumen central venous catheter is mandatory in all patients. The need for administration of chemotherapy, blood products, antibiotics, parenteral nutrition, and adjunctive medications over a prolonged period of time precludes the use of peripheral access sites. The use of a central venous catheter allows delivery of maximum concentrations of all medications into a high-flow blood vessel. Administration time is reduced and daily fluid infusion is minimized. After administration of the preparative regimen and before successful engraftment, allogeneic myeloablative hematopoietic cell transplantation patients undergo a period of pancytopenia lasting from 2 to 6 weeks. During this time, patients may require multiple RBC and platelet transfusions. Packed RBCs and platelets are usually given for a hematocrit less than 25% and a platelet count less than 10,000 per microliter or 20,000 per microliter. Transfusions with multiple blood products put patients at risk for blood product-derived infection, e.g., CMV, or hepatitis. In addition, sensitization to foreign leukocyte human leukocyte antigens, alloimmunization, may cause immune-mediated thrombocytopenia. Thus, blood product support in the myeloablative allogeneic hematopoietic cell transplantation patient must incorporate strategies that reduce the risk of viral infection and alloimmunization. Effective methods include minimizing the number of pre-transplant infusions, using single donor rather than pooled donor blood products, irradiating blood products, and filtering blood products with leukocyte reduction filters. Patients receiving reduced intensity or non-myeloablative preparative regimens may or may not experience neutropenia and generally have reduced requirements for blood products. In fact, many centers perform reduced intensity or non-myeloablative hematopoietic cell transplantation in the outpatient setting and admit patients to the hospital only for complications requiring more aggressive management. Several measures are recommended to minimize the risk of infection in autologous and allogeneic myeloablative hematopoietic cell transplantation patients. Private reverse isolation rooms equipped with positive pressure HEPA filters and adherence to strict handwashing techniques reduce the incidence of bacterial and fungal infections. To reduce exposure to exogenous sources of bacteria in immunosuppressed patients, low microbial diets may be instituted on hospital admission, and visitors are prohibited from bringing plants or flowers into the patient's room. Patients are encouraged to maintain good oral hygiene because the mouth can be a source of bacterial or fungal infection. Frequent, that is 4 to 6 times daily, mouth rinses with sterile water, normal saline, or sodium bicarbonate are effective. Brushing or flossing teeth is avoided during periods of thrombocytopenia and neutropenia. Aggressive use of antibacterial, antifungal, and antiviral therapy, both prophylactically and for documented infection, is an important aspect of patient management. Antibiotics with a broad gram-negative spectrum may be instituted prophylactically once the patient becomes neutropenic, basing on ANC and body temperature 38 degrees Celsius. Some transplant centers administer a prophylactic fluoroquinolone such as levofloxacin on admission, especially if the neutropenic period is expected to extend beyond 7 days. Fluoroquinolone prophylaxis during periods of neutropenia significantly reduces the incidence of gram-negative bacteremia, but generally does not affect mortality. Concerns regarding prophylactic fluoroquinolone use include the emergence of resistant organisms and an increased risk of streptococcal infection. In fact, the incidence of Viridian's group of streptococci has been increasing. Prophylactic antibiotics, e.g., penicillin, or vancomycin, are not recommended due to their lack of proven efficacy in preventing streptococcal infections and the concern about antibiotic-resistant bacteria. Regardless of prophylactic strategies, patients who become febrile during neutropenia should immediately receive broad-spectrum IV antibiotic or antibiotics, e.g., ceftazidime, cefepime, imipenem C-listatin, or meropenem, and prophylaxis should be discontinued. Antifungal prophylactic agents are commonly used in hematopoietic cell transplantation recipients. TSD is prescribed fluconazole 400 mg per day on admission because prophylactic use until day positive 75 post-transplant decreases the incidence of systemic fungal infection and fungal death in patients undergoing hematopoietic cell transplantation. The use of prophylactic fluconazole has been linked to reports of breakthrough infections with resistant fungi such as Candida glabrata and Aspergillus. When broader yeast and mold prophylaxis is required, either posaconazole or voriconazole may be used. However, data are limited in the transplant setting. If TSD were to require mold prophylaxis, Voriconazole 200 mg twice daily would be a reasonable choice. Voriconazole 200 mg twice daily was compared to fluconazole 400 mg once daily in a randomized double-blind trial for prevention of invasive fungal infections in standard-risk hematopoietic cell transplantation. No significant differences were seen in fungus-free survival, relapse-free status, and overall survival at 6 months. Toxicities were similar, and there was a trend toward reduced Aspergillus infections and less empiric antifungal therapy in the voriconazole arm. Posaconazole has also been used for mold prophylaxis in hematopoietic cell transplantation based on its efficacy as prophylaxis in neutropenic patients. However, data in hematopoietic cell transplantation are very limited. Both azoles affect the CYP3A4 isoenzyme, and their use with calcineurin inhibitors requires judicious monitoring. The use of broader-spectrum azoles has also resulted in the development of breakthrough zygomycosis infections, particularly with the use of voriconazole. The echinocandins have also been used for broader yeast and mold prophylaxis in hematopoietic cell transplantation. Micafungin, dosed at 50 mg IV every 24 hours, and fluconazole, dosed at 400 mg IV every 24 hours, were compared in a randomized, double-blind study of patients undergoing hematopoietic cell transplantation. Overall success was defined as the absence of suspected, proven, or probable systemic fungal infection through the end of therapy and as the absence of proven or probable systemic fungal infection through the end of the 4-week post-treatment period. The overall efficacy was greater in the patients who received micafungin, that is 80.0% versus 73.5% with a p-value equal to 0.03. Fewer episodes of aspergillosis occurred in patients treated with micafungin. On routine screening before transplantation, TSD is found to be HSV seropositive, that is equal to or greater than 1.11 index value, and VZV seropositive, that is equal to or greater than 1 index value. So my question to you is, how will this affect her management? Up to 70% of HSV seropositive patients undergoing myeloablative allogeneic hematopoietic cell transplantation will experience reactivation of HSV. Prophylactic acyclovir is commonly used in HSV seropositive patients undergoing allogeneic or autologous hematopoietic cell transplantation to prevent viral reactivation. Dosing regimens for prophylactic acyclovir vary widely. The dose of IV acyclovir is typically 250 mg per meter squared IV every 8 hours, whereas oral doses of acyclovir range from 600 to 1,600 mg per day. The recommended duration of acyclovir prophylaxis for HSV varies from day positive 30 to day positive 365 post-transplant or longer, depending on the specific type of hematopoietic cell transplantation and other risk factors. Valacyclovir, a prodrug of acyclovir with improved bioavailability, provides sufficient blood concentrations to prevent HSV in patients with mucositis or gastrointestinal acute graft versus host disease. Prophylactic valacyclovir is commonly used at a dose of 500 mg orally every 12 hours. Varicella zoster virus, abbreviated as VZV, seropositive patients are at risk for developing herpes zoster, particularly after day positive 100 post-transplant. Prophylactic acyclovir reduces the risk of VZV reactivation. As with prophylaxis for HSV reactivation, the optimum duration of VZV prophylaxis is controversial, often extending to day positive 365 post-transplant or longer. Patients who are HSV seronegative or VZV seronegative rarely exhibit primary HSV or VZV infection, and are therefore not administered prophylactic acyclovir. If HSV does occur, lesions usually appear on the oral mucosa, nasolabial mucous membranes, or genital mucocutaneous area and can be managed with acyclovir at standard treatment doses. Because TSD is HSV and VZV seropositive, she is at risk for viral reactivation and should receive prophylactic acyclovir 400 mg orally twice daily, beginning 4 days prior to transplant and continuing until her absolute neutrophil count is greater than 2,500 cells per microliter for at least 2 days. TSD is also CMV seropositive. So my next question to you is, what is the significance of this finding and what measures can be taken to prevent reactivation of CMV? Cytomegalovirus has the ability to establish lifelong latent infection after primary exposure. In immunocompromised patients, the virus may reactivate, resulting in asymptomatic shedding or the development of CMV disease. The incidence of CMV infection, defined as isolation of the virus or detection of viral proteins or nucleic acid in any body fluid without clinical symptoms, and CMV disease, signs and symptoms consistent with CMV invasion into a tissue, in hematopoietic cell transplantation recipients is 15% to 60% and 20% to 35%, respectively. The most common manifestations of CMV disease after allogeneic HCT are pneumonitis, fever, and GI infection. In the CMV seronegative hematopoietic cell transplantation recipient, primary CMV infection or disease can be prevented by selecting a CMV seronegative donor and using only blood products from CMV seronegative donors. No anti-CMV prophylaxis is required in these recipients. In patients who are CMV seropositive or who have received a CMV seropositive graft, antiviral drugs are essential to minimize morbidity associated with CMV reactivation or secondary infection. 2 general strategies are possible. Universal prophylaxis involves the administration of ganciclovir from the time of engraftment until approximately day positive 100 post-transplant. This strategy significantly decreases the incidence of CMV infection and disease compared with placebo. However, prophylactic ganciclovir therapy is associated with neutropenia in 30% of patients, which contributes to an increased risk of invasive bacterial and fungal infections. Neutropenia secondary to ganciclovir may lead to interruptions in antiviral therapy or necessitate administration of filgrastim daily or several times per week to maintain adequate neutrophil counts. The other strategy involves preemptive therapy, or risk-adjusted therapy. Using this strategy, patients begin therapy only if they have early reactivation of CMV detected through the assay of blood for CMV antigens, e.g., pp65, or viral nucleic acid using polymerase chain reaction testing. Using preemptive therapy selectively administers ganciclovir to only those hematopoietic cell transplantation patients at greatest risk for development of CMV disease. Antigenemia-based preemptive therapy is as effective as universal ganciclovir prophylaxis for prevention of CMV disease and is associated with reduced CMV mortality. The induction dose of ganciclovir is typically 5 mg per kilogram IV every 12 hours for 7 to 14 days, followed by a maintenance dose of 5 mg per kilogram IV daily until 2 to 3 weeks after the last occurrence of antigenemia or until day positive 100 post-transplantation. Preemptive therapy limits patient exposure to the potential toxicity of ganciclovir and thus reduces overall cost. Recent data suggest that oral valganciclovir is a safe and effective alternative to ganciclovir for preemptive therapy. Foscarnet may also be administered in lieu of ganciclovir, but its use is complicated by nephrotoxicity and electrolyte wasting. Monitoring and correction of electrolyte and fluid imbalances are essential when Foscarnet is initiated. C-dofovir is used to treat CMV in hematopoietic cell transplantation patients, but is reserved for use when ganciclovir or Foscarnet has failed. Dose-related renal dysfunction, which can be seen after even 1 or 2 doses, limits the number of patients able to receive C-dofovir. An advantage of C-dofovir is its infrequent dosing, making it conducive to clinic administration. Monitoring renal function, electrolytes, WBC, and intraocular pressure are essential monitoring parameters. Autologous hematopoietic cell transplantation recipients who are CMV seropositive pre-transplant should receive antiviral treatment preemptively as described previously. Non-myeloablative or reduced-intensity hematopoietic cell transplantation recipients should also receive preemptive antiviral treatment. Because host T cells may persist in the peripheral blood for up to 6 months after reduced-intensity or non-myeloablative preparative regimens, their presence may provide some protection against early CMV disease. A matched controlled study comparing the incidence and outcome of CMV infection in myeloablative and non-myeloablative hematopoietic cell transplantation demonstrated that although the time to onset of CMV antigenemia was similar in the 2 groups, fewer non-myeloablative hematopoietic cell transplantation recipients experienced CMV disease in the early period. The overall 1-year incidence of CMV disease was also similar, suggesting that non-myeloablative hematopoietic cell transplantation recipients are at increased risk for exhibiting late CMV disease, that is longer than 100 days after transplantation, compared to their myeloablative counterparts. It is therefore recommended that non-myeloablative hematopoietic cell transplantation patients receive preemptive antiviral therapy and be monitored for development of CMV antigenemia for 1 year after hematopoietic cell transplantation. TSD's absolute neutrophil count recovers to greater than 1,000 cells per microliter on day positive 20, and on day positive 32. A weekly surveillance blood sample is positive for CMV by PCR. Preemptive ganciclovir induction is initiated at 5 mg per kilogram IV every 12 hours for 2 weeks, followed by maintenance dosing of 5 mg per kilogram daily. After 3 weeks of therapy, TSD's surveillance samples are negative and ganciclovir is discontinued. Weekly surveillance sampling continues until day positive 100. If surveillance samples again become positive for CMV, ganciclovir therapy should be reinstituted. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 482.